to record this as well. So looking at those renal disorders here, the first one we're going to look at is acute glomerulonephritis. So this is that immune response to typically a beta hemolytic strep infection. So we can either get that through our skin or through our airways, breathing that in. And those antibody antigen complexes get trapped in the filters in our kidneys and cause inflammation and our inability to filter our urine here. So our causes of acute glomerulonephritis are going to be infection, other autoimmune disease, or vasculitis, where we've got inflammation in our vessels. So obviously, infections and autoimmune diseases are going to be our biggest risk factors. Complications are going to be kidney disease and failure, hypertension, and nephrotic syndrome. So what signs and symptoms would you expect to see in glomerulonephritis? Okay, so we said it was just caused by a strep infection. So that recent strep infection, it causes periorbital edema. So swelling just kind of confined to our face, around our eyes. And one of those major signs is going to be protein in our urine. We would actually have an elevated BUN and creatinine, and we said we see hyper instead of hypotension. So nursing interventions are going to be symptom management here. So keeping a close eye on our vitals, especially our blood pressure, our I's and O's. Just like with cardiac patients, pretty much any renal patient is going to be a daily weight and strict I&O. For these patients, we want to avoid sodium and potassium if they're showing edema. So we don't want to make that worse. We don't want them to be retaining any more fluid. So we want to stay low sodium, low potassium diet. During the acute phase where they're really edematous, we want to encourage bed rest. We're going to treat any high blood pressures with antihypertensives if we see them so that we don't end up with seizures. Monitor for heart failure and renal failure, which is going to be uncommon. Decreased urine output is going to be that early sign of renal failure. We can also look at our urine-specific gravity, telling us that our kidneys are no longer concentrating our urine. So with nephrotic syndrome, this is an actual physical disorder in our glomeruli or those filters where they become permeable to those plasma proteins. So this is going to have exacerbations and remissions. So it's a big, long roller coaster over several years for these patients. Can be caused by diabetes, other disorders, like anatomical disorders to the kidneys, neuropathy, or I'm sorry, not neuropathy, nephropathy. So we see this most often in our young kids, 2 to 3. They may also have an infectious disease, another kidney disease, or it can be a result of a medication. So with nephrotic syndrome, we have severe generalized edema over the entire body. These patients are lethargic, anorexic, can be really pale. They have frothy urine, lots and lots of protein there in their urine. So they have low serum protein in their blood because it all spilled out in their urine. And we also see elevated lipids in their blood rather than those proteins. We are monitoring them very closely for signs of infection. They're not able to remove those toxins and things from their blood through their kidneys. So high risk for infection here. That generalized severe edema puts them at risk for skin breakdown. Again, bed rests while we're edematous, and we can use steroids like prednisone to help pull out some of that excess fluid. So, because we don't have a lot of protein in our blood, sometimes our diuretics don't work well because they require protein to be able to move that fluid out of our bloodstream or out of our tissues. So, we may have to rely on a steroid to help with that edema. So, what types of things would we include in our care plan for a child with nephrotic syndrome? What would you expect to see? You guys can type them in or shout them out, either one. Yep, we're going to see that edema. What do we want to do as far as nursing interventions? What do we want to track? Yep, we're going to track our I's and O's, our daily weights. Yep. Can also measure our abdominal girth. That can tell us some of that swelling and edema that's getting worse. What about diet changes? Yep, we can give steroids to help reduce that edema. That low sodium, normal protein diet is going to be effective for them. Monitoring for side effects of our medications, infection prevention, going to be important for them. So, how do we tell the difference between glomerulonephritis and nephrotic syndrome? They're both very similar. So, we've got to look at that root cause. Glomerulonephritis is related to that strep infection. Nephrotic syndrome is not something, it's idiopathic. So, it's not something that we can control. We also look at the edema with glomerulonephritis. It stays mild and it's around the eyes versus that severe generalized edema. We look at our blood pressure. Is it elevated or is it normal? Based on that intravascular volume and the changes that we're seeing based on our kidney function. We can look at our urine. We can see the differences in color and kind of that frothy texture that we get with nephrotic syndrome. Also, the amount of protein in our urine. We only get a little bit with nephritis. Nephrotic syndrome, we have that massive protein in our urine. So because we've got that massive protein in our urine, we don't have a lot flowing around in our blood. So that low serum protein can also be a sign as to which disorder you're dealing with. Urinary tract infections, I think we're all pretty familiar with these. We've got to underlie or find that underlying cause. Were we exposed to a bacteria? Was it from a bubble bath, poor hygiene? Is it a complication of another condition like reflux? We know our females are most at risk because of their anatomy, and if they go untreated, we can end up with kidney and bladder infections. So, what are those signs and symptoms of a urinary tract infection that you would see in an infant? So, our infants tend to have those vague symptoms. So, any of these can be a symptom of a UTI in infants. Like I said, they're very vague. They just kind of don't feel good, and that tends to be how they present with this urinary tract infection. So pretty much a UTI can be any differential diagnosis anytime they come in. How about our older children? How are they going to present with a UTI? Yep, this is the same thing. This is all of them. We see these are the more traditional signs that we're used to seeing. So care plans for these. Always suspect a UTI, especially in an infant that is ill. Always a possible diagnosis. If we are seeing recurrent UTIs in our infants and our young boys, we might have a structural anomaly that we need to assess because they are less likely to have urinary tract infections. So we want to make sure that we are obtaining the correct specimen. So are we doing a clean catch using a urine bag or using a urine cup in an older child, making sure that they're cleaning before they're collecting, they're doing that midstream void? Or are we doing a sterile specimen where we're actually catheterizing that patient to get that sterile specimen? We want to make sure that we're doing that full course of antibiotics. We're not stopping early. We've finished the entire course. With our pediatric patients, it is common for them to have a recurring UTI but not show symptoms. So we're going to continue to do urine specimens even after they've finished their treatment to make sure that we don't have an asymptomatic recurrence. And then the education on prevention, also encouraging acidic oral fluids like apple juice, cranberry juice to make that an unpleasant environment for bacteria. With vesicoureteral reflux, this is where we've got abnormal backflow of our urine into the ureters from the bladder. So it's going from the bladder backwards up the ureters back towards those kidneys. It can be a congenital defect or it can be caused by high pressure in the bladder. Our Caucasian females up to 2 are at high risk, or if we've had a family history of this, or bowel and bladder dysfunction can be risk factors as well. So as you can imagine, if we've got a backflow of urine, we can cause damage to our kidneys, we can cause scarring, and it can also impact our blood pressure, so cause high blood pressure. So we want to make sure that we are taking good care of ourselves. So UTI prevention, stressing the importance of medication compliance, which is usually how we're going to treat those mild cases so that we can avoid having to do surgery. We can do surgery to change the angle of attachment between the bladder and the ureters to help stop that reflux and prevent kidney damage. If we have, because there's that strong correlation with family history, we may need to test siblings if we diagnose a patient with vesicoureteral reflux. And then after surgery, we want to make sure that we are keeping a close eye on that urine, measuring the output from the catheter, observing their dressing changes or their dressings and incisions. And sometimes we might have to restrain their hands so that they're not pulling and causing damage. Want to keep them well hydrated and manage their pain. Could be from that surgery or their bladder spasming now that we've changed the pressure. With our Wilms tumors, these are a malignant renal tumor that is encapsulated. So we're born with it. We have these abnormal cancer cells that are safely tucked inside of this protective capsule. So we typically will diagnose this um, by accident. Either parents will be bathing the child and will feel that abdominal mass, or a pediatrician on a normal routine visit will feel that mass. And that's typically how we end up diagnosing this. We can see any of those cancer symptoms as a complication of a Wilms tumor. Our African Americans are at higher risk, as well as those with a family history. What would we expect to find on assessment for one of these patients? Kind of gave this one away. Yep, we get that mass in our flank area around our kidneys, kind of stuck in that midline. We can also have fever, pallor, lethargy, elevated blood pressures. Very rarely we can have hematuria. Most importantly with these kids is we do not want to palpate their abdomen. So they will have a sign above their bed that says no abdominal palpation. We want that capsule to stay intact because it is holding those cancer cells safe. So it is keeping them in one confined location and not letting them free flow through our entire abdominal cavity. So we want to make sure we keep that capsule intact until we surgically remove the entire thing. We will also take that child's kidney, the affected kidney, along with it, so that we don't leave any of those cells behind and we're not risking rupturing that capsule around it. So after surgery, we want to keep an eye out for increased blood pressure. We only have one functioning kidney now. We want to monitor that function very well, looking at intake and output, our urine specific gravity. They will need an NG tube after surgery for that decompression, monitor for their bowels to return back. These patients will not be able to participate in contact sports after surgery because they will only have one functioning kidney. So hypospadias, we said our urinary meatus is on the underside of the penis. This will be corrected with surgery before we start potty training. So typically before 18 months, yes, 18 months where we start that curiosity. We also see castration anxiety, and we're starting that toilet training process. So we want to make sure that we are fully healed and ready to start all of those normal developmental milestones. Exposure to tetrogens during pregnancy, advanced maternal age, genetics, and family history can all cause hypospadias. Complications are going to be that abnormal appearance, difficulty voiding. We can also have that abnormal curvature called a chordee, altered self-esteem and body image for adolescents if it's not corrected. So what assessment findings would we expect to see? With hypospadias? So this is my day to desensitize you to select all that apply questions. So this is all of them again. So we've got that abnormal placement of our meatus. So that causes our change to our voiding stream. We can have that downward curvature to the penis as well. And sometimes we can also see undescended testes or inguinal hernias as a result, or in addition to these. Sorry. So how do we take care of these kids? We're going to help prepare them for surgery. Remember, we hold off on their circumcision just in case we need that foreskin for a skin graft. So we're going to do one big surgery all together. We're going to monitor their urine output afterwards. We might need a temporary solution to be able to drain urine after our corrective surgery. We want to maintain their hydration and then work on our discharge teaching. So they might need catheterized at home, need to know how to empty a drainage bag if they have a drainage device after their corrective surgery, how to prevent that catheter from coming out or being blocked, those signs and symptoms of infection to look for. With acute renal failure, we've got severe loss of kidney function. Most of our kids are able to regain their renal function if they've been treated promptly. So we can have renal failure as a result of dehydration, trauma, or obstruction. And those complications are going to be edema, muscle weakness, permanent kidney damage, and death. So if you had a patient with acute renal failure, what would you expect to see in your assessment, and what would we do about it? So start with your assessment things. What would you expect to see if our kidneys weren't working? If we're not able to filter our blood, what do you think you would see in your lab values? Yep, we could see edema, nausea, vomiting, flank pain, confusion, lethargy, electrolyte abnormalities for sure if we're not concentrating urine because our kidneys aren't functioning very well. How are we going to treat these things that we're seeing? Well, if we have electrolyte and abnormalities, we might have to give IV fluids, do some fluid replacement. We might need to restrict some fluids depending on what abnormalities we're seeing. So we're focused on correcting those imbalances. Also, if we're not feeling well, we're nauseous and vomiting, we're going to need some nutritional support along with that. So we talked about acute renal failure. That's that sudden onset, very abrupt renal failure. If we have chronic or long-term renal failure, this is where we've got that irreversible loss of our kidney function. So this happens over a long period of time, typically as a result of a congenital anomaly or a severe infection. Things like diabetes, hypertension, abnormal kidney structure, family history of chronic renal failure can make this worse. And we eventually end up in end-stage renal disease. So again, we're going to see those electrolyte imbalances. We can see anemia. We're going to be nauseous, have difficulty eating, so poor growth and development, fatigue. We can also see neurologic symptoms as those electrolytes start to build up. So we are going to modify our diet, maintain those fluid and electrolytes. Keep an eye on our growth, make sure that we're growing as we should. Medications to help support our renal system while we await transplantation, and encouraging and supporting our family along the way. So that is it for our renal review. So the last thing we have to review are metabolic and endocrine disorders. So like I talked about with hypothyroidism, we have inadequate thyroid tissue developing in utero. So we aren't secreting enough thyroid hormone or we're secreting too much. So with hypothyroid, we don't have enough. It can be an inborn error of metabolism. It can be an iodine deficiency, some sort of anatomical defect in that thyroid gland that's causing us to not secrete enough hormone. It can also be a medication exposure to the fetus or that long gestation. So if we're post dates over 42 weeks, then we can also be at high risk for hypothyroidism. And when we don't have enough thyroid hormone, it can cause cognitive impairment and also prevent us from growing appropriately. So on our newborn screening, our newborn metabolic screen that we do at 24 hours of life, we test their T4 and their TSH. So we will see a high TSH and a low T4 on their newborn screen. And that's going to be indicative that they are at risk for hypothyroid. We can also look at them and see they tend to be very large infants, very hypoactive, low tone, delayed meconium passage. They're poor feeders. Because they're poor feeders, they tend to be more jaundice. They have hypothermia. Like I said, everything slows down, so they don't produce a lot of body heat. Constipated because their GI tract slows down. They're lethargic and sleepy. We can see coarse hair and that large protruding tongue. So most of the time, these babies with hypothyroidism are the good, quiet babies. They wake up, they eat, they go back to sleep. They don't fuss. They're not really active. They're just good babies, quiet babies. So we started newborn screening in the hospital so that we could catch these conditions really early on so that we could treat them quickly and reverse some of these side effects or consequences that we see. So these patients will be on lifelong medication, at least for 3 years. We give thyroid medication first thing in the morning. We only give it once a day. Side effects are things like constipation. We want to make sure that we're checking our pulse before we give thyroid medication. Remember, too little can slow us down. That's going to be that sign of underdose of medication. We're going to see those hypothyroid symptoms again. If we have an overdose of medication, everything's going to speed up. So we're going to have that rapid pulse, irritability, fever, weight loss, diarrhea. So we teach parents to monitor for those symptoms that they can see in their child without having to do lab tests, but we will also do those periodic lab tests as well to get a really close eye on them. Phenylketonuria, or PKU, is an autosomal recessive disorder where we can't metabolize one of our amino acids, phenylalanine. So it's a genetic mutation, and it's caused by exposure to protein-rich foods. And it causes central nervous system damage, cognitive impairment, and decreased melanin. So that's what gives your skin its color. So these patients tend to have very fair skin and blonde hair. This is another thing that we assess for on that newborn metabolic screen. So we need patients to be exposed to at least 24 hours of food in order to assess their response to that amino acid. If it's a positive result on that newborn screen, then we'll repeat it a couple weeks later to make sure that it's not a false positive. These patients will also have frequent vomiting, failure to gain weight, can be irritable and hyperactive, and they have a musty smell to their urine. So it smells like a really old, damp library, is going to be that musty smell. So like I said, we do that newborn screening at birth. We can repeat it again at 2 weeks of age, making sure we didn't get a false positive. These patients will be on a lifelong low phenylalanine diet, so they will have special formula that they will have to use while they are strictly formula fed. And then they will have to have a phenol-free milk substitute after 2. And they have to avoid anything in their diet that could be high in phenylalanine. So high protein foods like meat, milk, dairy, and eggs. So lots of fruits, veggies, juices, cereals, breads, and starches. And we've got to maintain that diet until we've completed our brain growth. So at least 6 to 8 years. And then hopefully we can outgrow that. We also have to avoid NutraSweet or aspartame because it has phenylalanine in it. So we won't be able to have that. So artificial sweeteners are also bad. Type 1 diabetics. So these are our insulin dependent ones, that autoimmune reaction. Not processing glucose well. We've got our 3 Ps that we talked about: polydipsia, polyphagia, polyuria. That is what causes our bedwetting that we see in our previously continent child. We can also be irritable or fatigued, have weight loss, abdominal pain, nausea, vomiting. Typically, we see our type 1 in our pediatric patients. We are starting to see more type 2 diabetics in pediatric patients because of our poor lifestyle choices. So if we had a patient with ketoacidosis, what would we include in their plan of care? So you guys are totally right. We want to keep an eye on their vital signs, their glucose and electrolyte balance, as well as their neurostatus, because we can see those neurologic side effects with the ketoacidosis. We also want to keep an eye on their intake and output, making sure they're staying well hydrated, trying to filter out some of that glucose. So nursing plans with them, we're going to be reinforcing that home teaching. How do we give them insulin? Are they on a pump? Are they having to do self-injections? How do they test their sugar? With our type 2 diabetics, they are typically just on an oral medication, maybe have to do some sliding scale insulin. We're going to teach them dietary management, so carb counting. We might use the plate method, that sliding scale, how to adjust for meals and snacks, their growth and exercise. Remember, our kids grow at varying rates, so they are very unstable with their diabetes management. Increasing their exercise, making sure that they're doing it smart and making sure they're having a snack before they exercise so they don't get hypoglycemic. And then making sure that they are following up with their care team frequently. With school-age children, we have some special things that we have to consider. They're typically participating in physical education class, where they're going to be asked to do exercise. They need to have a snack beforehand, need to have those opportunities for snacks during the school day so that they aren't having those hypoglycemic episodes. We also need to keep in mind that they're going to feel like an outcast, not being like their peers as they're having to check their sugars, not being able to participate in activities. So that impacts them the most. And we are seeing an increase in our type 2 diabetics because we are seeing obesity on the rise. And that is all I have for you guys tonight. Do you have any questions about anything that we covered?